only mode.
Good evening, ladies and gentlemen, and welcome to the Eating Disorder Hope webinar for today. We have a special presentation on eating disorders, education, and awareness in nutrition, featuring special guest, Dr. James Greenblatt, who is the Chief Medical Officer and Vice President for the Medical Services at Walden Behavioral Care. And Dr. Walden has taken time out of his schedule to help address a very important topic that affects many individuals who are struggling with eating disorders. And just to go over some brief tools that are available to you as an attendee for our webinar today, you will have the opportunity to submit text questions to our presenter by typing your questions into the questions pane of your control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of today's presentation. So without further ado, I would like to introduce Dr. James Greenblatt and turn it over to him for his presentation. Thank you, Dr. Greenblatt.
Great, thank you very much. It's good to be here and to discuss with you something I've been particularly interested for my 15 years devoted to almost exclusively to the treatment of eating disorders. And when I started, after practicing psychiatry for many years, by accident, being on an inpatient eating disorder unit, I was really struck by the severe weight loss and malnutrition, but there was very little discussion and very little literature on starvation and vitamin and mineral deficiencies. You know, in my training and my interest has always been nutrition and brain function. I, as an example, always discuss pellagra, and pellagra is a B3 deficiency. It's a vitamin deficiency, a single deficiency that was epidemic in the United States in the early 1900s. And what happened for those individuals that developed this vitamin deficiency, they ended up in our psychiatric hospitals, and they would today be diagnosed as schizophrenics. So a B3 deficiency created first anxiety, then depression, and then a delusional disorder that looked identical to schizophrenia. And in the South, there are 1/4 to half of every psychiatric bed in the South of the United States is filled with patients with pellagra, a B3 deficiency. So I use this as a model to help my colleagues, physicians, dietitians, and clinicians understand that nutrition, one nutrient here, can have profound effect on brain function and create a delusional disorder. A similar model is the key study, which I think I hear we talk a lot about. But again, healthy males with restricted calories over a period of time, 24 weeks, they also developed obsessional thoughts, rigid thinking, some delusional around food, with many of the symptoms that you and I would call eating disorders. So nutrition affects brain function, and it is better now than when I started, but I do not believe that nutritional interventions are as aggressive as they should be. And I will talk with you this evening about two interventions, the trace mineral zinc and the essential fatty acids, particularly the omega-3s. But before, my last bit of kind of commentary is, why has it been so hard for the medical profession, not just in the field of eating disorders, but throughout psychiatry anyways, to really understand the powerful influence of nutrition and brain function? And there was a wonderful article written in the 80s called The Tomato Effect. And it was really based on, or kind of an explanation, if you will, as to why the medical community rejects sometimes very efficacious treatments. And the tomato effect was described because for 200 years in the United States, we wouldn't eat tomatoes. From the early 1600s to the mid-1800s, we wouldn't eat tomatoes. Why? Because we thought they were poisonous. They were part of the nightshade family. even though in Europe they were eating tomato during most of this time. And then it took a gentleman standing up in Salem, New Jersey, and ate a basket full of tomatoes and didn't die, that changed the culture. And the point of this article, written by two physicians, published in the JAMA, Journal of the American Medical Association, is sometimes the cultural norm cannot accept something that's out of what the paradigm is at the time. And tomatoes were toxic, they were poisonous, so we just didn't eat it. And for lots of nutritional therapies, it oftentimes, for our medical colleagues, is too simple and it can't be efficacious. So for those of you that studied, the history of eating disorders, we have descriptions from the 1600s, if not sooner. And as much as cultural attitudes have relevance to the psychopathology, I think it's quite clear to me and many others that it's unlikely to be sufficient to account for the profound neurological changes in the pathogenesis of these disorders. So the factors that may contribute to the onset of anorexia, which could be dieting, magazines, any other kind of environmental influence, whether it's a pediatrician telling their patients they need to lose weight, at some point there is a physiological dynamics that sustain the illness and I believe create the life-threatening disorders that we treat in our practice. So I have a number of slides tonight. I'm going to go through some quickly so I can get to some of the highlights and we have time for questions. But, we need to start off with, the vast majority of women are dieting and worried about health and weight, and now it's men as well. And what's the difference? Why? And I think genetics has clearly been shown to be a huge factor in eating disorders. Here you see anorexics, individuals with anorexia are 10 times more likely to have an anorexia relatives, and with bulimia nervosa, it's actually a 12-fold greater lifetime risk of having an eating disorder. So we know this huge genetic liability. It's probably higher than most psychiatric illnesses, 50 to 60% genetic liability, and that's why it's so important to get a good family history, 2 or 3 generations, because patients and families might not tell you there's a family history until you ask the questions. So we have this genetic kind of substrate that we need to understand. And then what I want to talk to you is about the adolescent brain and some of these environmental nutritional factors that kind of assault the adolescent brain. And here you see 3 pictures of a brain at birth, and then at 6 years of age you see all those dense, those are nerve cells, and then at 14 it gets a little lighter, and we call that pruning. And pruning refines these neural circuits. It's kind of like the bonsai effect. So we're making the brain more efficient by trimming these neurons, and it goes on throughout our life, but very intense for the first 20 years through adolescence and young adulthood. And the other thing that takes place in adolescence is what's called myelination. And this is something where we add fat, and it's literally fat, to these neurons to increase the speed by which the neurons work and the efficiency of how the brain works. So during adolescence, there's lots of energy going into pruning, and there's lots of fat that's being added to these neurons to help it operate more efficiently. So we know the genetic influences, and then we have this wonderful thing called puberty, and it's clear that there's some clash between these genetic changes and puberty. And I thought this patient described it eloquently. My childhood was perfection, full of vacations and love and family time. Something must have been lacking that no one was aware of. Something must have gone wrong. Maybe it was puberty. So there are lots of things in puberty, but my talk this evening is going to be on kind of the nutritional influences. The lack of nutrition is a better description. And we're all familiar with the SAD diet, the Standard American Diet. And these are just some samples. 25% of the calories for 2 to 19-year-olds can come from soft drinks, and most of our kids are not eating nutrient-dense foods. So it affects the brain. And I think if you've followed the nutrition literature and the lay press, it's quite clear now how processed food affects mood, behavior, and hopefully I can share with you how it affects the onset of eating disorders. So we have this standard American diet. I started my vegetarianism for health reasons, then it became a moral choice, and now it's just to annoy people. So one of my biggest concerns in the eating disorder community is not aggressively addressing vegetarian diets. I believe that vegetarianism is a real concern for our preteens and adolescents because of a number of factors. One, we're going to discuss the lack of zinc and B12 in a vegetarian diet. But more importantly, we have good data that's showing adolescent vegetarians are not as healthy as their peers. We have data also saying that adult vegetarians are healthier than their peers because our adolescent vegetarians are not typically in homes where the parents are vegetarians, which means they're not eating the beans and getting a wider range of non-meat foods, if you will. They're often living on pasta, chips, and maybe some lettuce. And that nutritional nightmare, I believe, creates significant nutritional deficiencies that encourage eating disorders. There's research, lots of research. I just have a few studies. This was a study done in Israel looking at 45 patients with anorexia to an outpatient clinic, never hospitalized. They were all zinc deficient at the time. And what we find is this abstention from meat, typically 1 year before the onset of anorexia symptoms. Okay, so becoming a vegetarian, there's usually a lag. Some studies were 12 months, some 18 months. In our experience, it's even less many kids. When I run a parent support group on our inpatient unit for parents of adolescents, I never bring this up, but usually one parent will start talking about my daughter or child becoming a vegetarian, and then everyone in the room will describe the same scenario. Now, we all know about the kind of big vegetarians are patients who will say they're vegetarian when they get into treatment so they can avoid fat or meat because of the caloric intake. But we're talking about the exclusion of meat products for 6 to 12 months prior to the onset of the eating disorder. And here are a few other studies. There are many, many more looking at vegetarianism and eating disorders. 68% of eating disorder patients felt there was a relationship between vegetarian and their eating disorder. Over 400 women with lifetime prevalence and 9,000 controls. Women with eating disorder 2 times more likely to be vegetarian. Lots and lots of studies making this correlation. And what I've taken the step further and saying this correlation is related to this nutritional deficiency that happens in puberty. And zinc is the part of the equation. Now, I'm not necessarily telling someone not to be a vegetarian. We'll get to that later, but a vegetarian diet needs to be supplemented with zinc and other vitamins, particularly for adolescents. Why? Adolescence is one of the few times other than pregnancy where there's a higher need for zinc. To get through puberty, we have a higher need for zinc. We know that stress causes increased need for zinc. Many of our eating disorder patients, particularly our anorexics, are athletes that are spending hours in the gym or on the field, and sweat is one of our major sources of losing zinc, so excessive sweating. Estrogen, birth control pills, there's news coming out today on the plastics and the environmental toxins, thousands and thousands of chemicals that we don't test. One thing is quite clear is they almost all bind zinc. And then celiac disease, I think, should be tested for in every early onset eating disorder patient. Celiac disease causes malabsorption of many nutrients, zinc in particular, zinc, B12, folate, iron, and then we get this increased need in puberty. So zinc deficiency creates many of the symptoms we're going to talk about. I'm going to go over later, but some of the simple ones are zinc is required for digestion. So when I started in this field, I remember sitting in the back of the treatment room, and patients would complain about their bloating and their GI distress and their pain upon eating, and the staff would just kind of say that's their eating disorder. This was 15 years ago. And as I got more interested in the field, it was clear that our patients do struggle with distension and pain on refeeding, and there are significant physiological abnormalities. And part of that is this inability to produce acid and digestive enzymes, and zinc is critical to produce all the digestive enzymes from the pancreas and the stomach. If we take any animal and deprive them of the trace mineral zinc, and then we try to refeed them, they will get very sick and often die due to lack of zinc. So refeeding a zinc deficient animal usually results on death. So we've been talking about zinc for many years, and there were a number of studies. They started in the 80s. When we summarize all the studies, the literature is strong enough that any medication that we have for anorexia nervosa, it's listed in many of the guidelines, including the American Psychiatric Association, but not trickling down to clinical practice as much as I would like. This is just one study looking at 14 adolescents and healthy controls. Zinc intake was low on admission. There were delayed sexual development, hair loss, skin abnormalities, and lack of taste, which is a classic symptom of zinc deficiency and something we see in many of our patients. And here, after 6 months of zinc supplementation, 50 milligrams a day, in this case control study, all patients improved in all areas that were looked at: depression and anxiety, and improved taste. And then here's a summary of the 5 major studies that were done. The original study I quoted also in here. And I'd be happy to send anybody these references. They're not particularly great studies, but they do look at adding zinc for the treatment of anorexia nervosa. They're all positive with improved parameters in both weight and mood and anxiety. The only one was the 1993 study where there were only the Zetlask study, where there were only 3 of the 7 subjects completed the analysis. So to me, 3 subjects don't make a research study, and it's very hard to make sense of it. But there is research to support it, and in our clinical experience, we found tremendous benefit of supplementing with zinc. We look at zinc plasma levels in all our patients, and you'll see that they are markedly low. And we also look at what we call functional markers of zinc deficiency. A white blood cell is a zinc-dependent enzyme, as well as the enzyme alkaline phosphatase, which is often low in our anorexic patients. Depression is comorbid in 80 to 90% of our patients with anorexia, and there's been an increasing review and literature across the world, actually. Many of these are international studies looking at zinc and depression. We have, this is a meta-analysis looking at 17 studies. This were not eating disorder patients. Depression associated with lower concentration of zinc. And then we have studies looking at adding zinc to those patients who were depressed. This is just one of the many studies with zinc that I wanted to share with you. And it was a number of years ago, but it was really well done. It was a research unit. So this was a research unit, 33 eating disorder patients. All the patients admitted. We then followed for 4 weeks for anorexia and 3 weeks for bulimia. They were all zinc deficient on admission. And it was a double-blind, placebo-controlled trial. And this graph is really important. Let's look at the box in red first. And those patients, let's just take our anorexic patients that were on this unit for 4 weeks. When they left the hospital, their zinc levels were lower than when they were admitted. So you see the bar graphs. Their admission levels were low, and they were lower when they were discharged. Why? Because as their metabolism started working, as they started digesting food, making enzymes, creating the metabolic energy necessary to digest and restore weight, they utilized much of the zinc, even though they were getting the recommended daily allowance of zinc. On the left, you'll see those that were supplemented with zinc. So zinc supplementation was the only way they were going to get the zinc levels up. So that for a minute, I just want to come back to that. But here's kind of the big picture of the zinc summary, of our work over the years looking at zinc deficiency in the development of anorexia. We have this genetic vulnerability, we have puberty, higher needs for zinc, and then we have this vegan-vegetarian clash that for many of these kids results in frank zinc deficiency. And zinc is required for all the things here on the screen. You need zinc to make serotonin and melatonin, so all the sleep problems that we see associated with eating disorders. We talked about the GI distress and bloating because you need zinc to make all the digestive enzymes. Increased vulnerability to stress due to zinc deficiency, changes in opioid receptors, pain sensitivity with zinc deficiency, decreased taste. I mentioned that our taste buds are zinc-dependent enzymes, which means our patients that are zinc deficient don't taste food. So we see all the time, if you ask the right question, our patients will add Tabasco and mustard and lots of very strange food combinations so they can taste something. This is also common in our geriatric patients who are zinc deficient. They don't taste their food and stop eating and become further depressed. Zinc is critical for essential fatty acid metabolism, we're going to talk about in a minute, for menstrual cycle and appetite, attention difficulty. Zinc is prevalent zinc deficiency and attention deficit disorder, and we talked about depression. So it's this setup that creates tremendous changes in the GI tract and the brain. And let's go back to this slide for a minute. So if we do not supplement with zinc, our patients are refed, they eat, and then they leave the hospital with less zinc than when they came as their body starts. So then if we go back to all these symptoms of zinc deficiency, what we're doing by not supplementing with zinc in any of our treatment programs, we're kind of setting up this chronic relapsing course. Because when they leave the hospital, right? They're leaving the hospital on discharge, low zinc, they're going to have struggles with refeeding. They're going to get the bloating. They're going to get the anxiety, the depression, the difficulty with taste. And that's going to just generate this relapse cycle without supplementing with zinc. So I've talked about zinc deficient anorexia for 4 hours at a time. It's fascinating biochemistry. The book that I wrote, Answers to Anorexia, is primarily a plea for parents to, if you're a vegetarian adolescent, is adamant about being a vegetarian, make sure you supplement with zinc. And we see changes, and we'll get to that. But I want to get to the other nutrient that just as important as zinc is the need for fat in the brain. So our obsession with fats has done little to our obesity epidemic. It certainly has kind of wreaked havoc, I think, with our eating disorder patients. These essential fats, both cholesterol and the essential fatty acid, we call the omega-3 fatty acids, are critical for every aspect of brain function. 60% of the brain is fat, and if you've been following the literature, We found that these essential fatty acids are associated with anxiety, depression, suicide, psychosis, perceptual changes, aggression, and GI problems. So if we take a step back and look at this list and look at our eating disorder patients, they are struggling with all the above. Our patients with eating disorders have avoided fat, sometimes for many, many years. Many individuals have described eating disorders as essentially a fat phobia. We've all seen patients who will not touch butter or fat. We have patients that can't sit next to a butter or a piece of meat because of their fear of fat. The literature on essential fatty acid deficiency is extensive in both the academic medical circles as well as basic science circles. So how do we understand how this fits in? And I'm just going to share with you something that has taken, I think, the community a while, because in the 80s it was hard to describe our adolescents as delusional, but many of these kids cross that line. A delusion is a fixed false belief, and again, it's beyond a fat phobia for many of our patients who refuse to eat or drink, who worry about gaining weight from saline and water, patients who can tell us that they gain weight as they're chewing the food, and they ask me to see how big their thighs are, how it's growing as they're chewing on their food, and that chronic ED voice. So this distorted body image, oftentimes that creeps into just this delusional picture, can be addressed if we better understand how fats work in the brain. So these were two brilliant studies I'm going to share with you, one done in 2010 and a follow-up study done last year, 2015, by the same group. These were not eating disorder patients, but these were young adults that had subthreshold psychosis. This is a term been used in child psychiatry for many years. Kids that had delusional thinking, magical thinking, or at risk for psychosis. And I would put many of our eating disorder patients in that category. They were giving a fish oil pill, 1.2 grams, a very small amount, a couple fish oil pills, or placebo for 12 weeks. So we're talking about 3 months of taking 1 or 2 pills a day. And they were followed after 40 weeks. Only 5%, 2 of the 41 developed psychosis, and 28%, much higher group in the placebo group. So the conclusion is these omega-3 fatty acids reduce the risk of the progression to a psychotic illness and could offer safe, efficacious strategy for the prevention in young adults. So this group followed 71 of these 81 subjects for 7 years. Really very difficult, and they followed the conversion to psychosis. And here you see the cumulative conversion for psychosis was less than 10% in the omega-3 group and 40% in the placebo group. And much higher functioning of the omega-3 group. And here on antipsychotic medications, 30% in the omega-3 group, over 50% in the placebo group. So a simple intervention affected the onset of psychosis for over 7 years. This is another study looking at dietary intake of omega-3 and vitamin D, 33,000 women. And adult women with a higher intake of fish, omega-3, had lower rates of psychotic-like symptoms. And, you know, as much as our patients can relate to us and are articulate and oftentimes are incredibly insightful of other people's behavior, their distorted body image is profound, and it does meet the definition of a fixed false belief, which is a psychosis. This is a patient, the quote, "You don't see what I see," which really woke me up to the different perceptual changes our patients have, where this young lady, 20-year-old, stood up on a chair in a family meeting when I first started 15 years ago and screamed at the top of her lungs, "You don't see what I see," to try to help me and her parents understand what she saw. So the sad reality for a disorder of fat deficiency, for something that is quite clear to all of us in the field, our patients have restricted fat for many, many years. There's very few studies. Eitan, who's in Europe, did one case control study and has written about essential fatty acids and anorexia. And this was her 10 patients receiving 1 gram of fish oil, EPA, for 3 months. And in her study, 43% recovered and 57% showed improvement in the symptoms. There is now increasing literature. This was written up last year, very, very well done review on the role of essential fatty acids in anorexia nervosa and obesity. And I encourage you to look up through this for much more information. There was one study adding omega-3 fatty acids to antidepressants. This was a group of individuals who did not do well on Celexa, and fish oil was added to the Celexa with significant improvement. Our patients clearly do not do well on the antidepressants. There's no research to support antidepressants, and part of the reason is the malnutrition, and here we see an augmentation strategy of omega-3 fatty acids helping the antidepressants. There's also augmentation strategies for zinc and other nutrients. There was a major article published in the Journal of the American Psychiatric Association from Harvard Medical School looking at adjunctive nutraceuticals. This came out last month in the treatment of depression, essential fatty acids, vitamin D, and folate being described. The other concern I have is, you know, how do we understand the dramatic suicide risk that our patients struggle with? And part of what is profoundly clear from the literature that our patients with anorexia and actually all eating disorders have the highest mortality rate as well as the highest suicide rate of any of our other psychiatric illnesses. One of the reasons is malnutrition, and we talked a little bit about that. We're going to talk about that with the essential fatty acids. But the other one is the antidepressants and the use of antidepressants. For 15 years, I practiced child psychiatry, and I never saw suicidal ideation with an antidepressant. And when the black box warning came out that these medications caused increased suicidal ideation, it just didn't make sense to me. Until I started working with eating disorder patients where I see it all the time. And these are just, you know, 3 case examples. And I put them here because the suicidal ideation that we see with our eating disorder patients on antidepressants are not necessarily due to low weight. These were all 90 to 100% ideal body weight patients who developed acute suicidal ideation on the antidepressants, and the suicidal ideation stopped as soon as the medications were stopped. And I believe that's because even though they were close to ideal body weight, they were still malnourished. Here, the suicide rate from the CDC, which just came out, dramatic increase, 25% overall, and then this triple 200% increase in young girls 10 to 14 years of age. I don't know if you kind of read that, but it is a profound increase. On the Walden website, we wrote a kind of white paper trying to explain that, and with talking about malnutrition, the antidepressants, the social media implications of this incredibly frightening statistic. I'm going to jump back to what I was talking about, the essential fatty acid, and this deficiency of fat has clearly been associated with increased risk of suicide. The earliest studies was with the military. We know we have vets dying every day, 25 plus vets committing suicide every day. This was a study looking at U.S. servicemen who committed suicide. We had blood done on all these individuals before they were in the service, and low blood levels, okay, of DHA, an essential fatty acid, predicted suicide. And I don't have all the other studies, but there are many, many other studies looking at essential fatty acid deficiency, the omega-3 deficiency that I referenced here, affecting the onset of psychosis, that also affects suicide risk. We have studies continued in the military confirming this relationship, studies done in other parts of the world confirm this relationship, as well as national NIMH studies confirming this relationship. So we think of fat, and we think of our young patients who have restricted fat, or our older patients who restricted fat for many years, and this quote just really hits home. So by modifying the natural fats, we have altered the basic building blocks of the human brain, weakening cerebral architecture, unstable buildings that come apart in an earthquake or a storm. Poorly structured human brains are failing to cope with the mounting stress of modern life. Again, the brain is 60% fat, serotonin receptors, oxytocin receptors. The brain does not work well without adequate fat. We've done autopsies on suicide victims and victims matched controls who died of natural causes or motor vehicle accidents. And the suicide victims have dramatically lower levels of fat in the brain. It's not a quick fix. We say it takes 3 months to change your oil. This was one study looking at 10 weeks to change the cerebral membranes with these healthy fats. So often our patients, certainly our parents, are looking for that quick fix, and they start taking the essential fatty acids, and my daughter's not better in 2 weeks or a month, and they give up. But it is a process. It's 2 or 3 months. But to me, it's one of the most important foundations with zinc supplementation. So kind of as a review, we have this genetic vulnerability that as long as you take a good family history, you will appreciate that. And then we have the temperament, the rigid perfectionist, obsessive young men and women that are more prone to eating disorders. A low birth weight is a risk factor. And then we have this major onset of puberty. And with puberty and the stress, we have nutritional deficiencies, essential fatty acids, and zinc just being 2 of the many nutritional deficiencies we see. Bariatric surgery, a very quick, like celiac disease I mentioned, a quick way to malnutrition. We're seeing dramatic increases of patients with eating disorders 2 to 5 years following surgery for obesity. So I think really critical if we start to look at zinc and essential fatty acids and just nutritional deficiencies as it relates to brain function, that we begin to develop a model for prevention. So if we have this high-risk young 12-year-old who goes on a vegan diet with that family history, or parents go through a divorce, we begin to maybe look at preventative models, getting them to therapy earlier, perhaps giving them a multivitamin if they're vegetarian, perhaps nutritional counseling at a much earlier age before the onset of more distorted body image and food restriction. You know, I talked about Maudsley Approach, and I think this has been incredibly well researched, important part of it, but what really happens? What happens to these kids that we neglected for so many years? We're feeding them. We're getting basic nutrients before the illness creeps to a malignant, life-threatening course. So Maudsley Approach does provide nutrition quickly before these kids go down. So, you know, in my world of nutrition and brain function, I just make sure everyone understands we're not talking about alternative medicine. In our patients with anorexia nervosa, starvation is a hallmark of the disorder, and we can't wait till it gets, you know, with irreversible bone damage and kidney and heart damage. The nutritional support needs to start aggressive and early on. Our treatment is pretty much random with our psychopharm. These are just books that our patients use for different eating disorder programs in New England. They call a doctor based on what medication. And the punchline here is that the antidepressants have not been found to be helpful with anorexia nervosa, even though 60-70% of our physicians prescribe them. These are just 2 studies. We don't have time to go through them. So we don't have medications to offer much help for our patients, and nutritional support is critical to our psychotherapy and nutrition counseling. So to me, this was just kind of mind-boggling that we sent a little spaceship up 10 years ago, and for a 3 billion-mile journey to end up to take pictures of Pluto, and we have yet to come up with a cure and a well-researched protocol for the treatment of the most life-threatening illness we have in childhood, anorexia nervosa. To me, it was just a mind-boggling feat of science. 10 years, 3 billion miles, we sent up a little spaceship to take a picture of Pluto, and we're struggling to treat our patients with anorexia nervosa with evidence-based science. So in my work, I'm a psychopharmacologist, nutritional biochemist, if you will, and I try to make things simple, but I know it's not. This was a true story. A patient, I started taking liquid zinc, and after 3 days I had an appetite. As a patient on our unit, I felt hungry. I was scared, and I stopped the zinc. There's a complicated part of the work that we've chosen to do for our help with patients with eating disorders, or for those families struggling with a loved one with eating disorders. It's not always simple. Nutritional support is a foundation. So I'm going to end with this story. This was an incredible story of a true story published in 1967. It was a gentleman in Florida who was trying to sell his orchard. He had a large orchard of oranges, and they were not producing any fruit. So he put up these acres of land for sale, and he nailed for sale signs in along the highway. And the next season, all the fruit that had those for sale signs, all the trees that had the for sale signs in them, bore oranges. And the reason is because the nails that they used were zinc-plated nails. So adding zinc to his trees produced these incredible fresh fruits that he wasn't getting. And to me, it's, you know, a very elegant metaphor about the importance of zinc and life and health in our youth. I'm going to stop there. These are some of the books that I've written trying to educate our colleagues and patients and families of how nutrition affects brain function. Anorexia and binge eating, you know, really focus on some of the nutrients, particularly zinc, essential fatty acids, B12, iron, etc. So why don't I stop and try to answer questions you might have.
Wonderful. Thank you so much, Dr. Greenblatt, for this fantastic and very interesting presentation. We're going to go ahead and transition into the Q&A portion of today's presentation. And as a reminder, you can still submit questions through the question pane in your attendee control panel. So Dr. Greenblatt, one of our first questions from our attendee is wondering about the nutrition deficiencies in bulimia and if that is being studied and if there's similarities to anorexia.
Some of the early studies that were done also demonstrated patients with bulimia nervosa were also zinc deficient. There hasn't been as many follow-up studies. In our research looking, and at Walden at this time, we've treated over 17,000 patients in 13 years. So we see a large number of patients with bulimia that are zinc deficient. In my experience, I would say something like almost every anorexic patient, and I probably wouldn't say every, but certainly the majority are deficient in these nutrients.
Thank you for addressing that. Second question from an attendee is wondering if there is a standard protocol for refeeding anorexic patients that is based on some of the literature that you have discussed in your presentation?
Well, I think the refeeding literature is primarily focused on calories. And I think it's been nice to see over the past 5 years that things have changed enough where more aggressive refeeding, a more caloric intake more quickly has been shown to be both helpful and effective. What has been missed in the literature is the nutrient supplementation. So on our units and in my practice, we're just supplementing with zinc. It's not mega dosages. It's 30 milligrams twice a day. It's essential fatty acids. It's a B complex. And depending on individual, if there are other deficiencies like B12 and vitamin D. But the zinc, B complex, and the essential fatty acids, I think, are critical, as well as probiotics does provide some relief for some of the digestive complaints many of our patients report.
Great, thank you. Another question we have is there any research in terms of length of time for effectiveness of supplementation?
The research studies that we have were short term. The longest was 6 months. And we have found most patients will need supplementation for 6 months. Some of the most dramatic success stories we've had, particularly with older women that have struggled for many, many years, they have found supplementation beneficial for at least a year. One of the things that in the starvation literature for prisoners of war who've starved, oftentimes what happens under acute stress and starvation is something called vitamin dependency. And some individuals just develop higher needs for nutrients for long periods of time. And this was seen in prisoners of war in World War II. There's not a lot of literature with eating disorder patients, but I do have some patients who just require higher doses of certain B vitamins in particular for extended periods of time.
Thank you, Dr. Greenblatt. Next question from one of our attendees is wondering, is there a suggested dosage or kind of EFA, and is cod liver oil a good idea?
Cod liver oil is great. When I started this 13 years ago, it was just amazing how many patients wouldn't take a fish oil pill because they looked at the bottle and they saw the 10 calories for 2 pills. Nowadays, the same patients with anorexia, they will take it because culturally they've been bombarded between infomercials and reading, the lay press that fish oil is good for you. So they'll take the pills now, but they'll deduct their 10 calories somewhere else. Cod liver oil is fine because it has vitamins A and D in it, but again, getting your patients to swallow it might be hard. We try to get as much as we can. I think if we can get 3 grams of fish oil total a day, it would be incredibly helpful for our patients with anorexia nervosa.
Thank you, Dr. Greenblatt. And we received another question asking something similar about zinc. Is there a certain form of zinc that is better for patients for supplementation?
Well, at this point, I think all the forms of zinc are fine. I think the omega-3 fatty acids, I would be careful and buy them from a company that respect, and I wouldn't go to a drugstore to get fish oil, but any form of zinc, so zinc sulfate, zinc picolinate is fine.
Thank you. Another question from our attendee is wondering, what is the application for outpatient providers who are treating patients with eating disorders? Do you have any suggestions?
Would you repeat that one?
Yes, sorry. I'm wondering, what is the application for providers who are treating patients with eating disorders in an outpatient setting?
Well, to me, the outpatient setting is where we can begin to look at this model of prevention, that we can, just provide some literature to our vegan, vegetarian, adolescents so their parents understand that we're not going to force anyone to eat meat, but they might need nutritional supplementation. It could be working with a pediatrician. It could be providing articles, or books on nutrition, or getting a referral to a dietitian sooner. So I think this model has much more implications for our outpatient providers, so we can prevent the real destructive side of this illness. Again, the misplaced blame that I talked about initially, there are many reasons that someone might start restricting their calories, but if we can prevent that downward spiral to this pervasive, kind of mind rigidity around the obsessional thinking, then we can provide more help for our patients.
Great, thank you. Another question from an attendee: should copper be prescribed alongside zinc?
Good question. For most adults that we would recommend, if you give too much zinc, you get a deficiency of copper. And I've seen that. We've seen it in autistic kids, parents getting carried away. I've seen it in adults taking too much zinc because they've read an article. And they end up with copper deficiency, and copper deficiency results in depression. But our anorexic patients, we typically use just zinc because most of them are so zinc deficient for at least 3 months before we would add a multivitamin or a balanced zinc and copper. So a couple milligrams of copper to every 15 to 30 milligrams of zinc is important for adults, but not necessarily to start off with our anorexic patients. I just use zinc for 3 months initially.
Thank you. Another question: is there ever a case where zinc is counterindicated?
Well, certainly the ideal is to be testing for zinc deficiency, some of these markers. But the dosages that we're recommending, if the RDA is around 15 milligrams. So we're not recommending much higher than what a minimum requirement would be. So if we're sticking to 15 to 30 milligrams, I don't see any contraindications. I do see over 100 milligrams for extended period of time potentially creating problems. I see no contraindication to 15 to 30 milligrams, particularly a vegan, vegetarian individual who's not getting adequate zinc from their diet.
Great, thank you. And we have one final question. Where would you like to see research in this area in the next 10 years?
Well, I mean, something that I've been trying to get off the ground for many years is, are there markers of zinc deficiency that we can identify early? And one of these is this enzyme called alkaline phosphatase. And as our adolescents grow, the bones produce alkaline phosphatase, and it's very, very high. And in our experience, our anorexic patients have very low levels. So if we can begin to look at zinc deficiency in all of our high-risk adolescents by not only looking at plasma zinc, but also these other markers like alkaline phosphatase, I believe that with a good research study, we'll be able to develop a model to both supplement zinc early and prevent the devastating turmoil that goes with the development of eating disorder.
Thank you so much, Dr. Greenblatt. We appreciate your time giving this fantastic presentation, very interesting, and thank you so much for taking the time to address the questions of our attendees today.
No problem, I appreciate it, and if anyone has any specific questions or wants the references, just email me and we'll get them to you.
Wonderful, thank you. And can you just share what that email contact would be for you?
Let's see if I can. The contact at James Greenblatt, MD, is probably the simplest.
Okay, wonderful. Thank you. Thank you again, Dr. Greenblatt, and thank you everyone for attending today's webinar. And if you have any other questions, please feel free to contact us at info@eatingdisorderhope.com. Once you leave today's webinar, you will receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to review a recording of today's webinar. So on behalf of Eating Disorder Hope and our presenter, Dr. Greenblatt, thank you for joining us today and enjoy the rest of your day.